In this explainer, we're going to break down the practical management of melanoma step by step. We'll be using the Australian and New Zealand clinical practice guidelines to build out an evidence-based workflow that you can actually use in your practice. Okay, so let's dive right in. We're going to follow the entire patient journey, really from the moment of first suspicion, through the biopsy, the definitive surgery, all the way to creating a solid long-term follow-up plan. So first things first, clinical diagnosis. Look, we all know the classic ABCD rule, right? But our diagnostic toolkit really needs to be a bit broader, especially when we're talking about some of the more aggressive types of melanoma. Now, this is where it gets really interesting. The ABCD rule, it's fantastic for those initial, flat, superficial spreading melanomas. But nodular melanomas, they often play by a completely different set of rules. And that's where the EFG rule is absolutely essential. Elevated, firm, and growing progressively for over a month. They just look and feel different. So what's the big takeaway here? It's that one size does not fit all. Knowing when to switch gears and apply that EFG lens is critical. It can literally be the difference between an early diagnosis and a missed one. Okay, so moving on. Once a lesion has you suspicious, how you do the biopsy is just paramount. It sets the stage for everything that follows. And this brings us to a really common question, a dilemma that we all face in practice. What's the right way to biopsy this thing? Do you go for a complete excisional biopsy, or are there times when a partial biopsy is okay? Well, the guidelines are super clear on this one. The gold standard, the best practice, is a complete excisional biopsy. You want a narrow 2 mm clinical margin, and you need to go deep enough to get into the upper subcutis. And a key point, aim for primary closure. You really want to avoid flaps or grafts that could mess things up for the later wide excision. But, clinical practice is full of nuance, isn't it? The guidelines do recognize that there are specific situations where a partial biopsy might be the better call. Think about large lesions on the face or on the hands and feet, places where a full excision would be really impractical. Or maybe the clinical suspicion is just very low. The huge caveat, though, is that a partial biopsy might not tell the whole story, so you have to be extra careful with clinical correlation. Okay, so we've got our confirmed diagnosis. The path report gives us the Breslow thickness. Now it's time for the definitive wide local excision, and this is where we really lean on the data to guide our surgical margins. This table lays it all out beautifully. It's a fantastic at-a-glance reference for planning your surgery. For melanoma in situ, you're looking at 5 to 10 millimeters. For those thin melanomas, up to 1 millimeter, a 1 centimeter margin is the standard. And as you can see, as the Breslow thickness goes up, so do the margins, right up to 2 centimeters for those thicker tumors. But, and this is a big but, it's so important to know where the evidence gets a little blurry. For those intermediate melanomas, the ones between 2 and 4 millimeters, the optimal margin is still up for debate. Is it 1 centimeter or 2? Well, this is where it really comes down to clinical judgment, where the tumor is, and a good conversation with the patient. All right, that brings us to the next critical decision in our workflow, staging the regional lymph nodes. This is all about the sentinel lymph node biopsy. First, let's just do a quick refresher. A sentinel lymph node biopsy, or SLNB, isn't a treatment. It's a highly specialized staging tool. The whole point is to find and check that very first lymph node the tumor drains to, looking for any microscopic signs of spread. So who should we be talking to about this? Well, the guidelines recommend discussing SLNB with any patient's melanoma is thicker than 1 millimeter, and that threshold actually drops to just over 0.75 millimeters if there are other high-risk features in the pathology report. It's also absolutely crucial that this is done before, or at the very least at the same time as, the wide excision so we don't mess up the lymphatic drainage. And that brings us to our final section. After all the treatment is done, the patient's journey isn't over. It just shifts into a new phase. And this is all about a smart, risk-adapted, long-term surveillance strategy to watch for recurrence and any new primary melanomas. This table really nails the risk-stratified schedule. You can see how the intensity of follow-up is directly tied to the initial stage. For stage I, it's pretty straightforward, once a year. But as you move into stage 2B/C and stage 3, that follow-up gets much more intense, every 3 to 4 months in those first couple years, which is when the risk of recurrence is highest. But here's the thing, those clinic visits, they're only part of the story. And this number right here is why. It's so important to remember this.
Up to 75% of melanoma recurrences in Australia are actually found by the patients themselves. That single fact completely reframes what follow-up is all about.
So, the most crucial takeaway, and this quote from the guidelines just sums it up perfectly, is that our most important job in long term management is to empower the patient. When we educate survivors about their own personal risk and teach them how to do effective skin self exams, we transform follow up from just a series of appointments into a continuous, lifelong partnership in their own care.